Welcome to the Rapporteur session for the 2020 STD Prevention Conference. We're going to wait a few seconds till all of the attendees have come into the session, and we will start the session then. So this afternoon in Atlanta, I am delighted to present to you 3 science rock stars from the Division of STD Prevention at the Centers for Disease Control. I will introduce all 3 of them so that I do not interrupt their presentations later on. First, we have Laura Hadurjanai, who has earned her PhD in health behavior from Indiana University. She's an epidemiologist in the Division of STD Prevention, and her work focuses on health inequities and disparities related to sexual health. Second, we will have Lieutenant Commander Jenny Bowen, who earned her PhD in reproductive health from Johns Hopkins School of Public Health. She's also an epidemiologist in the STD Prevention Division, and her work focuses on antibiotic-resistant gonorrhea detection and response, dual HIV syphilis rapid test evaluation, syphilis outbreak response, and congenital syphilis surveillance. Finally, last and definitely not the least, we have Brian Raphael, who earned his PhD at the University of Arizona, who leads the gonorrhea, chlamydia, and mycoplasma genitalium team in the Division of STD Prevention. And his work is focused on antibiotic sensitivity testing for gonorrhea, whole genome sequence analysis, and development of molecular assays for the detection of STD pathogens in clinical specimens. With that, I'll turn it over to our rapporteurs. Laura, please.
Just move it to the start of the presentation. Okay. So I'll start with a disclaimer that the following is the opinion of the author and does not represent the official position of the Centers for Disease Control and Prevention. So our conference theme this year is 2020 Vision, Disrupting Epidemics and Dismantling Disparities. And hindsight really is 2020. If only we had known what this year, 2020, would bring, because at the beginning of this year, we had a plan and we had a vision. But as we all know, then the COVID pandemic happened. And instead of us in public health and healthcare disrupting the STI epidemics, the COVID-19 pandemic has disrupted all of us, as well as the STI epidemics, and shone a spotlight on the inequities and health disparities that predated the pandemic. So not only has the COVID-19 pandemic created change and uncertainties, but it has allowed us in the STI prevention world the opportunity to do things in new ways. So for this Rapporteur session, we would like to highlight for you some of the ways that the STI field worked before the pandemic and some of the novel and innovative ways that we have adapted during the pandemic and may move forward. So we have separated these presentations into 3 areas. First, I will discuss the sociocultural, programmatic, and behavioral sciences. Next, Jenny will discuss surveillance, health services, and epidemiology. And finally, Brian will discuss the laboratory and clinical sciences. So before I get started, I'd like to thank all of you for your hard work every single day, especially under the current circumstances. Your work keeps the STI field moving forward and keeps these conferences so interesting and engaging. So again, thank you. And if you aren't familiar with the scene from the TV show Schitt's Creek, I highly recommend it. So as previously mentioned, we'll discuss the sociocultural, programmatic, and behavioral issues. So I'd like to highlight some of the factors that were brought up during this conference and realize that these do not obviously encapsulate all of the sociocultural, programmatic, and behavioral issues. But for the sociocultural level, there are several critical issues that were brought up, including racism as a public health issue, the impact of incarceration on individuals and networks, persistent hookup culture among young people, and policies including confidentiality and explanation of benefits for health insurance, and various protections for sexual and gender minority folks. At the programmatic level, the themes highlighted at the conference included systematic collection of data and using the data that have been collected, evaluating and measuring program success, using non-traditional partnerships and methods, communication, including storytelling, clarifying definitions, and shifting language, and the importance of building trust. At the behavioral level, of course, we continue to look at sexual behaviors, but we also look at other behaviors that may impact sexually transmitted infections, like the use of dating apps and substance use. Researchers have also highlighted healthcare-seeking behaviors, such as acceptance and use of telehealth or telemedicine, and the acceptability and use of at-home or point-of-care STI tests. And finally, there's an emphasis on taking a holistic approach, not just for sexual health for individuals, but also considering intersectionality and holistic approaches within healthcare, public health organizations, and across our entire field. And then further, we'll look at the potential impacts of COVID on these three levels. So we'll start with the sociocultural level. And this is a great overview of the social determinants of health disparities from Kellen Baker's Access to Care for the LGBT Community. And unlike my summary today, this framework is much more comprehensive and lists numerous structural, policy, and social influences that we don't have time to further dive into right now, but they are all important. However, I do want to focus on one of the critical determinants, which is racism. So as Drs. Mena and Maybank described on the first day of the conference, and Drs. Tuxson and Kellum on the fourth day of the conference, the racial disparities in sexually transmitted infections, and similarly for COVID-19, are not new disparities, but a result of historical forces created by a legacy of racism and discrimination in the United States. Thankfully, more jurisdictions have started to state that racism is a public health crisis, and many researchers continue this important research. Another structural factor that is tied to racism is incarceration. So as Kim Blankenship noted in her presentation about mass incarceration and the social determinants of health, many of the social cultural factors are interlinked and have an impact on STIs. We also see colleagues from New York State that use correctional settings as a promising place to identify, treat, and prevent STIs such as syphilis. And it will be some time before we see the impacts of COVID-19 on our research and the societal and structural factors on racism and incarceration. But besides these larger structural factors, there's also an emphasis on some cultural factors, such as the hookup culture. So from Lisa Wade's presentation on hooking up, she described the hookup culture and the negative implications for sexual and mental health. In this area, she was also able to provide some thoughts on the potential impacts of COVID-19 on these cultural practices, and projected that it may give us a chance to rethink the practices, and that isolation may lead young people to yearn for more meaningful interactions, that they may make young people more receptive to protecting themselves from other infections such as STIs, and that we're all having to think more about consent. So things like having to wear a mask, similarly having to wear condoms, right? So while we may see some shifts in cultural practices, it is unclear what will happen to policies. So Joanne Brown emphasized the importance of confidentiality and explanation of benefits in her presentation for continuity of care and prevention for youth. Further, she shared best practices for programs and offered ways to address confidentiality concerns with young people. But besides young people, researchers are also focused on policies related to sexual and gender minorities. So as Kyle Bernstein mentioned in his presentation on STD risk behaviors among MSMW, many sexual minorities encounter unique forms of stigma and shame, which have implications for their sexual health and care. And further, Dorothy Esplanage shared implications for schools in her bullying LGBTQ youth presentation for how schools can enhance existing anti-bullying programs and the importance of providing resources for students. And these presentations are just a good example in connection to our programmatic components, which come next. Oops. So an important element of the programs that came up several times throughout the conference was data. And I know data aren't just used in programs, but it is an important aspect for our programs. As Marianne Carter mentioned in her presentation about CDC perspective, we need to increase the buy-in for data collection and keep in mind that perfect performance measures remain elusive. Even though we understand that there aren't perfect measures, there's still a lot of things that we need to collect. As Steve Evener and Dorothy Esplanage pointed out, there is a dearth of data for sexual and gender minorities. And Wiley Jenkins pointed out that we need more data in rural areas too. And there are sources of data that we've not traditionally tapped into very often, as Philip Wolf described. He included analyses of social media and the use of machine learning. So with the COVID-19 pandemic, we know that there will be an impact on STI programs and research. And many of the locations where people were receiving services and where researchers were collecting data were closed during the pandemic. And I look forward to hearing how those programs will adapt and have adapted in future conferences. So one way that COVID-19 may impact how we collect and share data is through data exchange and electronic case reporting. So G. Oakley gave an example of how they're looking at the exchange of data. But we know that through COVID-19 systems, that may change all of our systems throughout public health, which could impact STI reporting as well. And another important aspect of programs, obviously, is evaluation. So many researchers shared evaluation projects, such as Chad Hendry's presentation about the community-based STI Express Clinic in Chicago, and Karen Nikoshia's presentation from Ohio. Marianne Carter also pointed out that we should be clear about what we are measuring, what the intended use is, the importance of measuring success and sharing the progress, and interpreting the data alongside other information that we may have collected. And David Harvey from NCSD shared the implications that COVID-19 may have on our programs, including contact tracing and disease intervention specialists, with an emphasis for how we can support our field staff and programs through training, technical assistance, and documenting what is happening in the field. So I also look forward to hearing more about those studies and how that has changed in the midst of COVID. So even before COVID-19, researchers were looking at non-traditional partners and methods for programs to extend STI prevention. Kiana Dobson and Asha Moore described one successful example in Los Angeles, partnering with faith leaders and organizations. Further, Adrienne Hens described an alternative condom distribution program in Texas and how their program is overcoming common structural barriers to obtaining condoms by providing the condoms online with free shipping, predominantly to young people. Since those sales are online and the marketing is through social media, they were not really impacted by like the brick and mortar locations that provide condoms during the COVID-19 pandemic, and they are able to still supply condoms. So while they saw a dip in online ordering in March and April, orders have now surpassed the rates that they found in January. Another example of programs meeting people where they are comes from Allison Decker in a pilot study of rapid syphilis testing among women experiencing homelessness in San Francisco. And they were able to provide testing and treatment while in the field. And I think these are all great examples of how programs are reaching out to people in need of resources and care. So related to this, another important aspect of programs is communication. This is a critical way for the programs to reach out to public health or to the public. And as Julia Marcus described on the first day of the conference, the framework and language that we use to discuss STIs as well as COVID-19 are important to share information and increase public health. And we saw this theme throughout the conference as Dorothy Espelage emphasized minimizing language that marginalizes and stigmatizes, and Erica Samoff stressed how effective storytelling can be. And communication is also one of the key building blocks in establishing trust. So several of our presenters focused on building trust, as Dr. Tuxson, Marian Carter, and Suzanne Grebe all emphasized. We need to continue to build that. So Suzanne Grebe further described 4 distinct themes from research from Black sexual minority men, including an authentic engagement with the community, increased transparency of research process, capacity building for staff, and a balance of research and action. So that brings us to behaviors. And as I mentioned, researchers continue to measure sexual behaviors, as Brian Emerson and Christine Kasparor both presented about MSM and sexual behaviors. Brian found that a substantial number of MSM reported group sex, and Christine found shifts in behaviors that may increase risk of STIs. And then Rob Stevenson shared among transgender youth an intervention that could impact sexual behaviors, including the use of PrEP. So many of the studies presented at this conference were in the pre-COVID era, though there were some results on the impact of the COVID pandemic. So on the first day, Katie Renfro succinctly summarized all the current research related to COVID-19 and sexual behaviors, and Ken Mayer similarly described one of those studies in greater detail. So far, the studies indicate that the use of online apps increased during the pandemic, but we don't know how that use has impacted behaviors. And for the behavioral studies, we have seen a decrease in the quality of sexual interactions and some new sexual experiences and changes in sexual acts, but those vary based on relationship status and sex and gender. We did have, I did want to highlight at least 2 posters presented at this conference with a focus on the impact of COVID-19 on sexual behaviors. From Tulane, colleagues found that nearly half of the young Black men in New Orleans did not have any sexual partners during the stay-at-home orders. And among the half that did, most left home to have sex with those partners. And few of the men in this study received sexual health services or information about safe sex practices. And from Emory, colleagues, among PrEP using MSM, most participants decreased sexual activity with casual partners, and a quarter reported challenges while attempting to access sexual health services. And prior to the pandemic, we saw that studies from Jackie Jennings and Jessica Wagner saw that online meeting spaces and app use may be a critical touch point to reach Black MSM. And during one of the debates, Lisa Hightower reminded us that technology isn't the iceberg, it's just the tip. And people crave social connection, and social media, the dating apps, are just one way to find that. And then among others, Stephanie Strathy and Jackie Jennings discussed the urgent need to address the substance use crisis and syndemic between opioid use and STIs. And that's not just at the individual level, but there are behaviors that researchers are focusing on. So for seeking healthcare access, we saw from Wiley Jenkins and Rob Stevenson that there is acceptability for the use of at-home or point-of-care STI tests. And from Ken Mayer, an acceptability for the use of telehealth and telemedicine. And while we don't expect all medical and clinical care to go to telehealth, it will be an interesting venue to see how that will change in the future. So several presenters at the conference focused on a more holistic approach, as Robert Garofalo presented this quote, which I believe he said he presents often because it encapsulates what so many of our patients and folks focus on, not just STIs, but also jobs, housing, food security, and health access to quality healthcare. And Kyle Bernstein presented in the lower left-hand corner the multiple dimensions for MSMW and bisexual men to not just focus on behavior, but also consider their community, identity, and attraction. And then in the top right-hand corner, I borrowed this graphic from Steve Evener's presentation to show the roots of this healthy tree include all of the aspects of the social determinants like we saw in one of the first slides. And then finally, from Jomana Muzmar's presentation about the CARB plan, the One Health approach as well, and encapsulating everything that we could have to move forward. So as Dr. Milbrandt emphasized on his excellent opening plenary talk, COVID-19 has exposed flawed systems, institutions, and people. And due to technical difficulties, he wasn't able to present his last few slides, but he was able to tweet them. So I did want to share that, he shared his wish list moving forward, which I think is similar to a lot of the participants for this conference and the things that people would like to focus on as we progress in our field. So finally, I just wanted to close with what the future will bring. One of the many topics that I did not touch on, but speakers such as Casey Pinto discussed, are the cost of STI screening and treatment. And so this cost issue is obviously really important from a programmatic perspective, but also an individual perspective. And we will have to sort of wait and see what will happen with funding in the future. And then if you haven't already seen yesterday's Political article, people aren't just thinking about how the COVID-19 pandemic will impact the STI world, but also how our world can impact and help fight COVID-19. So I'd like to thank everyone who shared their presentation for the Rapporteur sessions, as well as my colleagues on the slide. So I'll pass it on to Jenny.
Thanks, Laura. I am delighted to be with you all today. That said, I might be one of the few people attending conference this year who is secretly happy that we are meeting in a virtual way. Yes, I really do miss seeing all my STD colleagues, some of whom I only get to see on like a biennial basis with FaceTime. But the reality is this uniform doesn't fit very well anymore. It hasn't for like 6 months. and my gray hair is now much more prominent than it used to be. And the reality is I've had better days, and I'm guessing that you've had better days. And I think if I had to pick a new STD slogan or motto for most of our programs, it would probably be, we've had better days. So I'd like to try to walk you through some things, some highlights from the conference today related to surveillance, health services, and epidemiology in light of kind of the times and in light of what might be coming down the road for us. So I want to take a moment to introduce you to a character that I met in this conference. His name is Oddlaw, and as you might be able to tell from his very unique garb, he is actually a character from the Where's Waldo series. And he's described by Waldo fans as mean, nasty, loathsome, and disgusting. His number of good deeds are few, and all he really cares about is getting his hands on that prized walking stick. When I first heard of Oddlaw last week, I thought he was an excellent representation of my current arch nemesis, COVID-19. Just like Oddlaw is mean, nasty, and loathsome, I find that COVID-19 is the same. And it's going to substantially change the way that we do business in STD prevention and control. Certainly for a little while, maybe even for a long while. So I have an opportunity today to tell you about how Oddlaw, or COVID-19, has and may continue to impact the areas of STD surveillance, health services, and epidemiology. As I see it, we've entered a place where this is our past normal. These are the things that we did before COVID-19. This represents our bread and butter when it comes to surveillance, health services, and epidemiology. We've also got this new normal that we're living in. This represents all the changes that we've experienced in the past 6 months and that we might continue to experience due to COVID-19. These include changes to our workforce, changes to our clinic volume and flow, changes to our ability to do routine STD prevention work. We've heard at this conference about the new normal for surveillance, health services, and epi. But lastly, there's also a future normal. This is part of the Rapporteur gig that I enjoy the most, which is the opportunity to wildly speculate about how COVID-19 might leave an indelible mark on the field of STD prevention. And unlike Oddlaw, it might not all be bad. We may find that COVID-19 provides us with some really great coattails on which we can hitch a ride when it comes to surveillance, health services, and epi. Look for these icons throughout the rest of my talk. Let's start with our bread and butter in surveillance. We are really lucky to have a pulse on STDs due in large part to the fact that 4 STDs and HIV are nationally notifiable conditions. Having this much case report data certainly doesn't mean it's perfect. I know some of you are cynics out there saying right now, Jenny, come on, it's so incomplete. I get that, it's not perfect, but look at what our colleagues in influenza have to deal with just to maintain a pulse on influenza. There's convenience sampling, there's estimation, and there's extrapolation just to make sure at the end of the day, you don't look like a convenience sample. We're kind of fortunate to have nationally notifiable conditions at the heart of our surveillance. I want to share with you a few things that I gleaned from the conference that are based on this bread and butter of national case report data. For example, Dr. Ann Kimball found that although overall numbers of CS-related deaths are increasing with the nation's increasing CS burden, the case fatality rate for congenital syphilis has remained fairly constant over the past 6 years at 7.7%. Unfortunately, racial and ethnic disparities do exist in this case fatality rate, with Hispanic women delivering a higher proportion of infants who are stillborn or early infant deaths. Case report data at the local level were also able to help Dan Newman determine that the proportion of adult syphilis cases attributed to repeat infection has been climbing steadily in Florida over the past 8 years. And similarly, Jim Mathias showed in Florida that repeat infection during pregnancy is relatively common, with 7% of all pregnant women who are eligible for reinfection actually becoming reinfected. Both of these studies point to the utility of case report data in helping us identify groups who may need extra intervention. Margie Smith of the Illinois Department of Health illustrated how case report data are being harnessed for what we might consider data's highest purpose, which is data to action. I like to call this interventional surveillance, and it really makes me happy to see programs exploring opportunities like this with case report data. The surveillance team at the state program developed a query that can identify 2 gonorrhea infections in a 60-day period. If the first infection is deemed treated, the second infection is flagged for immediate follow-up by a local health department to assess for potential gonorrhea treatment failure. Of over 300 such flagged episodes, only 1 was deemed to be a true treatment failure, and this person was successfully retreated, and a test of cure later came back negative. This is something that we never would have known without attempting something like this. We also saw multiple posters documenting how health departments are using routine gonorrhea case reporting to investigate trends in disseminated gonococcal infection, or DGI. In both Virginia and North Carolina, researchers documented a low proportion of cases identified as disseminated, about 0.1% in both states. However, both authors commented that and cautioned that these are likely underestimates of true burden. In addition to national case report data, STD surveillance has long had a history of sentinel surveillance to explore other meaty issues that are not captured in case report data. Many of you are familiar with the STD surveillance network, which has recently expanded to include neuro and ocular syphilis. This study by Robin Hennessy of New York City found a low burden of neuro and ocular syphilis, which confirms findings from other jurisdictions. But among cases with neuro and ocular symptoms, only 35% of patients received a lumbar puncture, and only 27% of patients received CDC-recommended treatment for neurosyphilis, which does require hospitalization. At follow-up 3 months later, 10% of patients were still exhibiting symptoms of neuro and ocular syphilis. Dr. Sancta St-Cyr's work, highlighting 2019 preliminary GISP data, tells a quick but important story. Although 76% of gonococcal isolates in 2009 were considered fully susceptible to antimicrobials of interest, that's the green piece of pie here, that number had fallen all the way to 45% by 2019. The nearly 35-year history of GISP allows us to monitor crucial trends in antimicrobial-resistant gonorrhea. And don't forget about extragenital infections. While GISP, from the last slide, is based solely on male urethral isolates, there are an increasing number of surveillance systems looking at extragenital infections through SURGE and eGISP. Work by Christina Tybalt and colleagues in Washington showed that there may be some differences in antimicrobial susceptibility by anatomic site, with a higher proportion of extragenital isolates demonstrating azithromycin resistance, shown here in the red circle, although small numbers may limit statistical comparison. And work by Laura Quilter and colleagues demonstrated likely geographic differences in susceptibility patterns, with sites from the West Coast having a higher proportion of isolates demonstrating elevated azithromycin MICs. Now, this is the way that we've done business for a while, relying on our mainstay of case reporting and sentinel surveillance. Then odd law came along, and that really here represents COVID. He bowled us over with almost 100% of the US population being under stay-at-home orders during the month of April 2020. The impact that this quarantine has had on surveillance for our STDs is profound, as shown in Hillard Weinstock's symposium on national surveillance. All 3 major nationally notifiable STDs have taken a huge hit in case reporting, beginning in mid-March 2020. As you can see from the dark blue line on this graph, which represents chlamydia, the hardest hit has been seen by chlamydia, likely due to its heavy reliance on asymptomatic testing. And given that late 2019 and early 2020 case numbers were already projecting that 2020 might be a year of gonorrhea increases, the substantial loss of reported cases in spring and summer of 2020 has left everyone searching for new ways to describe STD trends. When it comes to our new normal, one of the most devastating blows that we've taken is the reassignment of a large proportion of the DIS workforce. David Harvey's talk highlighted that close to 80% of STD disease investigators have been reassigned for COVID duties. This means that STD investigations, which not only generate information for partner services, but also generate invaluable information for surveillance, have come to a grinding halt in many places. As Sue Blank put it best, reprioritization is the name of the game. And only some cases will be investigated during these trying times, which means data quality may suffer even for the cases that are reported. Now we need to think forward to a new normal that might wait for us on the other side of COVID. My 130 days of COVID deployment have taught me many things about how surveillance is conducted for other pathogens, especially respiratory pathogens. And there are many systems that we don't tap into on a regular basis that are hugely important for our colleagues in flu and COVID. That might include syndromic surveillance, sentinel surveillance in emergency departments and outpatient clinics, and the use of health information exchange data to plug sizable surveillance gaps. We don't need to bemoan the losses that COVID has brought to STD surveillance. Instead, we really need to ask ourselves, might the benefits of COVID linger longer past COVID itself so that we can use some of these methods in our own work in the future, like identifiable health information exchange data to plug holes in our surveillance systems? Erica Samoff reminded us in her Q&A that COVID has really highlighted how flexible we can be when we need to be. Let's explore what seems promising in our post-COVID reality. Will Geisler and colleagues from the University of Alabama took a very innovative approach to monitoring the burden of chlamydia among young women. And they asked the question, are we really underestimating burden by relying solely on NAT testing? And they found that the answer is probably yes. So when they included additional data to measure past infection, like asking women if they'd been previously infected, and when they used chlamydia antibodies in the serum as a marker of past infection, the cumulative prevalence of chlamydia infection actually increased quite sizably. And they've concluded that including chlamydia antibody tests more than doubles cumulative prevalence. In California, Nicole Burghardt explored the utility of a statewide hospital data set available through her local emergency preparedness unit as one way to perform surveillance for neurosyphilis in the state. She used a series of codes to identify likely neurosyphilis and then compared the key demographics in the hospital data set against neurosyphilis cases sitting in California's STD surveillance system. She found that overall case numbers were quite comparable, although they did begin to diverge a bit over time. And she also found some key differences between the two data sets, with hospital discharge data having a higher proportion of females than the case data sitting in the surveillance system, and also a higher proportion of persons over the age of 45. Unfortunately, the data in the hospital data set did not contain enough identifying information to be linked back to case data, but this effort may be worth continued improvement. And this is an area where COVID may bring us all along into the future. Jenna Slutzker of New York City used national vital statistics data to identify almost 1,300 neonatal herpes-related deaths in the US during a 22-year time period. Given the lack of national reporting for neonatal herpes, efforts like this are one of the few ways that we can reliably explore trends in neonatal HSV. This study found a consistent, increasing trend in HSV-related deaths among infants under the age of 1. And Anne Tollard introduced me to the concept of synthetic data sets created from electronic medical record data. These data sets use data point replacement, kind of like the type of analysis that you might do to impute a missing value, to create artificial data sets that maintain the statistical properties of the original data sets. The benefit, though, is that these new data sets are no longer identifiable at the individual level, and they're not considered really overseen by human subjects research any longer. This means it might be easier to share these types of data sets with outside entities, like public health departments and surveillance units. Anne demonstrated an example of synthetic data utility by showcasing a calculation of chlamydia positivity in a St. Louis hospital system. More validation work is currently needed before this has a widespread application for surveillance, but it's really nice to see things like this emerging on our collective radar. I want to end this surveillance section with a small cautionary tale about our future when it comes to mining big data, which has been my focus thus far. Carrie Mock and colleagues presented on the validation of a large commercial claims database In this data set, they were fortunate to have both lab results, and chlamydia results are shown on this slide, and they also had corresponding ICD-9 or 10 codes for each patient. Very concerningly, they found that 93.5% of all patients with a positive chlamydia lab result did not have a corresponding ICD-9 or 10 code that would have indicated a chlamydia diagnosis. This is a huge alarm sounding for all of us who might be looking to big data for exploration of lab-diagnosed conditions. Dr. Mock concluded that this is less likely to occur when we're talking about clinician-diagnosed conditions like PID, but it still gives us pause about our race for big data. I now want to explore the topic of health services for a bit, and I'm going to start by introducing you to some great examples of our bread and butter. Don't get me wrong, these are not stale studies, but these are really fascinating studies with novel findings. But they do, in a way, represent the way that we've always thought about clinical care and health services. In the past, we have asked people to come and sit in our clinics, often for hours at a time, and we've spent our time innovating around ways to make that care faster. For example, express testing, or more efficient, or how to make it more appealing for subpopulations like adolescents who may not be interested in joining us in that clinic. This study by Dr. Chad Henry highlights one such improvement effort that has been performed in a traditional STD clinic, the Howard Brown Clinic in Chicago. Dr. Henry found that a new express visit option was able to attract a high proportion of new patients, 57% in the express testing visit versus 20% in a non-express visit. And it was able to bring down average clinic time to 40 minutes for those choosing the express option or being eligible for it. He also found that people participating in express testing were more than happy to receive their test results by text message or patient portal, which further expedites the delivery of services. Though not shown here, this is really similar to some findings out of the Chelsea Sexual Health Clinic related to the very aptly named Quickie test. They were able to return test results to clients in hours, not days, although their study did not find substantial gains in return to the clinic for treatment using this new Quickie test. There's a continuation on this theme with the work of Dr. Mohammed Rahman in Louisiana. He found the new checks out system to alert patients of test results electronically by text message or email led to substantial gains in the number of people treated for chlamydia and gonorrhea and gains in the timeliness of that treatment. Again, we're finding ways to improve the clinic-based care that we've always relied upon. And these are huge wins that should not be devalued. In the world of pre-exposure prophylaxis, 2 studies at the conference, maybe more, point to the need to improve cis women's linkage to and retention in PrEP. Back in Chicago, Nick Love found that cis women were much less likely than men and trans women to be retained in PrEP. And this theme was echoed in the work of Christine Borges of New York City. Her catchy poster titled, "Where My Girls At?" reminds us all that offering women PrEP navigation is only the beginning of a long chain of events, and improvements are needed to reduce the dramatic drop-offs that occur after women receive PrEP navigation. But then odd law, or COVID, sneaks in during March of 2020, and we stop seeing patients in STD and other safety net clinics. This requires that we now innovate around how to improve clinical care, about how to get people tested and treated without a clinic visit. In general, folks start to get worried at this point. How are we going to diagnose that primary syphilis without an opportunity to actually see the chancre inside of a woman's vagina? Shutdowns are widespread, as Dr. Hillary Reno's map demonstrates in St. Louis, Missouri, where 28% of STI and HIV testing sites closed, and an additional 63% had to modify their services. This resulted in a sizable decline in gonorrhea and chlamydia testing, a 45% decrease across her 14 hospital healthcare system. Missed testing over 10 weeks totals approximately 4,500 gonorrhea and chlamydia tests and 5,000 HIV tests. And that, what I will call missingness, is not uniform across clinic venues. Sue Blank of New York City adds an additional layer to the story when she is explaining how New York City responded. They worked throughout the spring and summer to ensure that pharmacists could administer injections of ceftriaxone, and they distributed syndromic treatment guidelines to clinicians throughout the city. New York City's clinics also reduced their clinic services, reserving in-person appointments for the most, what they called, high consequence conditions. And to layer it on, Dr. Ken Mayer echoed this finding at Fenway Health in Boston, where they experienced the same thing. In this graph, you can see on the blue line that plummeting syphilis screening, which causes a rise in test positivity, the orange bars. Now, to expand further, you can see here that at Fenway Health, this was accompanied by an expansion in telehealth visits. But Dr. Mayer cautions that telehealth may not be the panacea. Many providers were willing to adapt with telehealth, and they were willing to forego or skip and delay STI testing for PrEP clients who may have been due for STI testing. While that seems well and fine in the short term, there are other things that make us more cautious, like reimbursement challenges that have limited the use of telehealth for some patients, as well as the digital divide. Some folks simply don't have access to smartphones or computers or don't feel comfortable using this type of technology. And video conferencing about sexual health is certainly a challenge for someone who may be home, perhaps with parents, like I'm thinking of college students who have not yet come out to their family. You will hear later on about the massive expansion and discussion around home testing, which has also accompanied kind of our new normal in this area. And that will come from Dr. Brian Raphael in a bit. I really want to say in wrapping up the new normal that there may be a silver lining in some of this. Medical and nursing students during the spring were losing out on precious practicum opportunities, maybe even to work in STD clinics like your own. And the one upside to this is that in that moment where they were losing out on practicum opportunities, Karen Bauer from the University of Washington found that many of them were being redirected to the national STD curriculum. In fact, the number of new learners jumped by 34% in March of 2020, and the number of new learners jumped by 87% over baseline in April of 2020. So perhaps a small positive amidst the other. So moving on to kind of where this might mean we are headed in the future. And again, some of this is prognostication here. It's important to point out, as Dr. Wiley Jenkins points out, that it is now time for us to recognize how complicated life is. And this means that we need to begin to meet people where they are. This picture comes from Dr. Jenkins' presentation on rural health. And as you can see here, I found this quite humorous. This looks like something that could have happened in my small town in South Carolina. This is actually a pharmacy drive-through attached to a True Value hardware store. And this is just one example, again, of how co-locating services may be the wave of the future. There are other ways in which rural health has really led this endeavor, especially when it comes to telehealth. So it might be time for our urban health kind of counterparts to take a lesson from the playbook of rural health. Dr. Jenkins provided a really specific example that I liked here. In rural Southern Illinois, there is a mobile service that provides a host of screening opportunities. So really the idea here is one-stop shopping. Life is complicated. Let's make it easy for people to get an HIV test and a hepatitis test and a syphilis test all at the same time. Maybe also while they're getting their syringe exchange. And so he found in this uptake, high success, but he also pointed out that it is important that this co-location is really designed in rural areas to overcome the barriers, the financial barriers that might be there for maybe a program that tries to operate on its own. The idea of bringing care to people where they are is certainly not new. Shaquetta Johnson talked about Louisiana's program that has been rolled out over the past year, which is designed to get field-delivered bicillin to women as needed in certain regions of Louisiana. And so this program called SHOT, which stands for Syphilis Home Observed Treatment, is kind of modeled after other directly observed therapy that we've seen in fields like tuberculosis. So public health unit nurses actually travel to women's homes and administer therapy, and they are currently measuring the outcomes that this might have for both syphilis treatment as well as for potentially congenital syphilis prevention. This study was already touched on really briefly by Dr. Hatters and I, so I'm going to kind of blaze through it. But in response to rising congenital syphilis rates in California, Allison Decker and colleagues implemented a rapid syphilis test project in an enclave or an encampment where people were experiencing homelessness. And they found that after administering 70 tests to women who were experiencing homelessness, they were able to identify 5 new cases of syphilis, which is about an 8% case finding rate. And they were also able to treat 100% of the women the same day. Case finding in jails is another opportunity to bring care and treatment to women where they are. There was a study rolled out in Dallas by Christine Dang and colleagues, which explored whether linking gonorrhea and chlamydia testing to urine pregnancy testing might increase case finding in jails. Maybe surprisingly or not surprisingly to some of you, this paired gonorrhea and chlamydia testing with urine-based pregnancy testing dramatically increased the number of women tested and the number of positive cases identified, and did not impact test positivity. I hate to do this, but I'm going to skip over a few slides here. I'm tight on time and didn't time this super well. I want to jump into epidemiology really quickly and wrap here. It's important to note that unlike surveillance and health services, we don't quite know the impact that COVID is going to have on epidemiology. It's possible that through delayed care seeking, many of the kind of relationships that we have considered to be tried and true may start to change a bit. I want to highlight some epi work that I found fascinating. Dr. Winston Ibarra, his case control study looking at the protective effect of gonorrhea, the protective effect that the meningitis B Bexsero vaccine may have on gonorrhea was really impressive. And I know I've boiled down an entire case control study in 2 cities to 1 slide, but the point here is that the Bexsero vaccine in a case control study using retrospective data appears to have an impact, 41% vaccine efficacy. This is now going to be moved forward into a phase 2 randomized trial of Bexsero across a variety of sites. And Jeannie Marazzo talked about this. This trial is really slated to kick off in fall 2020, and I'll be curious to see how it may be impacted by COVID. Lastly, I want to talk a little bit about pelvic inflammatory disease. Kristen Kreisel discussed and pointed out that we are seeing ever so slightly the upturn, perhaps, in PID in the most recent NSFG cycle. And this has some real implications for other work that's being done on PID right now around the nation. I want to end by talking a little bit about Sharon Hillier's interesting work that she's doing to try to identify biomarkers of pelvic inflammatory disease. She found that a variety of BV-related pathogens are strongly predictive of acute PID, and she's been able to develop this work further to look at both predictive biomarkers and diagnostic biomarkers. And we're excited to see where this work may go in the future. So in closing, I want to thank everybody that presented their work and their labor of love at this conference, especially those of you who contributed slides knowingly or unknowingly. And I want to thank those who helped me develop the slides and who were a part of this rapporteuring session. Thanks. And without further ado, I'm going to turn it over to Dr. Brian Raphael.
Thank you, Ginny. First, I'd just like to thank the conference organizers for the opportunity to provide an overview of laboratory and clinical presentations in this conference. I also want to thank my co-rapporteurs for being such a great team and helping to prepare for this session. So it should come as no surprise that the volume of STD testing has dipped during the first part of 2020, as we've heard in the previous talk. As an example, I want to highlight the 45% decrease in total gonorrhea and chlamydia tests in St. Louis that Hillier Reno presented, and also the data that Hillard Weinstock showed data from a commercial laboratory on chlamydia tests, again showing a steep decline here in orange on the right-hand side compared to the same period of time in 2019. So for the context of this session, I wanted to assess laboratory-based activities as shown here in the blue box through the lens of a pre- and post-COVID world. I consider post-COVID as starting around the time of the extensive stay-at-home orders in the US and going through the present. In this context, it appears that some planned activities had to stop or be postponed. As one example, perhaps a point prevalence study exploring in a population that's coming to a clinic for testing might be one such example. In other cases, laboratory operations may have been restricted, perhaps due to laboratory staffing decreases or limited staffing. These activities could have continued along, but perhaps been restricted and occurring at a slower pace. And then finally, in the post-COVID world, there may actually be opportunities to accelerate development or implementation of certain lab-based activities. So we heard many excellent presentations on laboratory and clinical science, and it would certainly be impossible to highlight everyone in every presentation in this particular session. But to focus this presentation on the pre-post-COVID framework, I wanted to concentrate on the following activities. And those included activities that support public health response and surveillance, the development of novel methods and performance evaluation. And I think a critical component of this is discussing the implementation of laboratory testing methods. And then finally, talk a little bit about the clinical trials that were discussed in this session, in this meeting. So in this talk, we'll concentrate on what we've learned in this area. How has the pandemic disrupted work in laboratory science and clinical science? Has the pandemic disrupted particular fields, and how has it? What are the metrics of those changes? And then finally, what is this new normal that's emerging, and what can we predict looking back at some of the presentations that we've heard? So let's start with laboratory studies that inform or support public health response and surveillance activities. So as Ginny mentioned in her talk, antibiotic-resistant gonorrhea, or ARGC, was presented by Sanctus and Craig in the Gonococcal Isolate Surveillance Project, or GISP, which is a sentinel surveillance program in which antibiotic sensitivity testing of GC isolates is conducted using the gold standard agar dilution method. Sanctus showed that preliminary 2019 data demonstrated continued increases in the proportion of GC isolates with elevated minimal inhibitory concentrations to ciprofloxacin and azithromycin, but MICs for ceftriaxone and cefixime remained low. Also, over the past decade, the proportion of pan-susceptible GC isolates decreased from 79% in 2009 to just 45% in 2019. The importance of culture capacity for understanding ARGC can't be stressed enough. Another program that deals with GC isolates is SURGE, or the Strengthening U.S. Response to Resistant Gonorrhea program. This program builds local capacity for the rapid detection and response to antibiotic-resistant GC, or otherwise known as ARGC. Here, AST is conducted locally using the e-test format. Kara Schleinger showed the distribution of isolates with elevated MICs to ceftriaxone, cefixime, and azithromycin over the first 3 project years of SURGE. Evelyn Nash showed the best culture yield at SURGE laboratories came from urethral samples, and that overall culture yield decreases as the time between the initial NAT specimen and the specimen collected for culture increases. So GC isolates also have a critical importance in genome sequencing, or whole genome sequencing. This has become a very important part of our understanding of GC strain populations. For example, genome sequences can help detect outbreaks, as Bob Kirkaldy's presentation in the session aptly named Genomics and STIs for Dummies discussed. Here, a cluster of tightly related isolates containing a specific macrolide-associated set of resistant markers was shown to have emerged and spread within a potential network in Indiana. Vasanta Chavukala showed a genomic analysis of GISP isolates from 2018, showing how this kind of genomic analysis can help us understand the spread of isolates with various antibiotic resistance determinants. In the slide shown here on the right, a clade of containing several isolates with elevated MICs to azithromycin is highlighted in the blue box. And as you can see, the analysis of these genome sequences reveals the presence of variants with respect to the MTR locus and to the 23S rRNA sequence, both of which are involved in resistance to azithromycin. Another study that we heard about was presented by Tatum Mortimer. In this study, GC isolates from New York City were subjected to phylogenetic analysis. And this study showed that the New York City isolates were really representative of a global population when overlaid with clusters from other studies around the globe. Tatum's presentation showed that the strain population from New York City was structured by sexual behavior and race and ethnicity. And as shown in this slide here, you can see that there are two lineages that are apparent, lineage A and lineage B. And lineage A is far more often are isolates recovered from men who have sex with men. Detection of potential transmission clusters as defined by a cutoff of 10 or fewer SNPs revealed that such clusters cut across demographic groups, and it does not appear to be driven by antibiotic resistance. So, taking a turn now to novel methods for performance evaluation, I wanted to sort of just highlight a few methods that that really cut across various STDs. First, I want to start with Christina Maro's presentation on various diagnostic assays for neurosyphilis. Here, the performance of the VDRL test was compared to various alternative diagnostic tests, and this was conducted with specimens from the University of Washington syphilis study. And here, the real-time PCR assay to detect the organism, the TPPA to detect the antibodies in CSF, and then interestingly, a cytokine assay for CXCL13 was discussed too. Notably, the diagnostic cutoff was not uniform in the cytokine assay, although the sensitivity and specificity in this assay seemed to be quite reasonable. Turning to antibiotic resistance detection, Eric Lin presented on the prediction of decreased susceptibility to ceftriaxone in gonorrhea. And he looked at 4 different mutations associated with decreased susceptibility of ceftriaxone. Here, various molecular algorithms were assessed on their sensitivity and specificity to predicted decreased susceptibility. And on the right is an example taking into account mutations in PON-A, MTRR promoter, and mosaicism in the PEN-A gene. One of the very large areas where we heard a lot of talks was around point of care tests, and this was very well laid out by Charlotte Gatos, who had several slides that I'm showing here on this particular slide. So Charlotte discussed several FDA-cleared assays, including the Gene Expert from Cepheid, the Binks Health assay for CT and gonorrhea, and then 2 assays for trichomonas, and also a point-of-care assay, the Syphilis Health Check. And I think she makes an excellent point on this particular slide in red text, saying that point-of-care tests for STIs go hand in hand with self-collected specimens, another really important and well-discussed topic in this conference. So just concentrating on 2 assays that she discussed was the Binks Genetics IO platform tests, and there was a separate talk from Barbara Vanderpool on this assay showing high sensitivity and specificity for chlamydia and gonorrhea. This is a 30-minute test using a single-use cartridge. It can be run by non-laboratory personnel, and the types of specimens it can use are male urine and vaginal swabs from women. The point-of-care syphilis health check was also discussed in detail by Jeffrey Klausner, who discussed this assay in great detail and also demonstrated the importance of understanding the role of population prevalence when using this test. And in areas with higher prevalence in the population, the positive predictive value of the assay was improved. There was also a very interesting presentation by Barbara Vanderpool on considerations for implementing point-of-care tests. And she presented a draft decision tree, which I wanted to highlight in this talk. And she talks about considering use cases for point-of-care tests, getting provider buy-in, and also understanding the populations and logistics in order to implement tests and make them work. And this decision tree is quite interesting. You know, if in here, the value of using the point-of-care test, trying to understand if a patient has symptoms or if they're a contact of a patient has symptoms, and then what to do with that result. Would there be value in testing for AMR or sending specimens to another laboratory for additional analysis? And just also wanted to navigate my slides. I also wanted to discuss implementation of rapid testing in the New York City Chelsea Express Clinic. This was a clinic with high volume and rapid turnaround, and assays for GC and CT tests in self-collected urine, rectal, and oropharyngeal specimens were performed on the Cephea Gene Expert Infinity. This has a 90-minute runtime, and the interesting thing about this assay that was presented by Cecilia Kretz was that these can be individual tests. They don't require batch testing, and so it can be kind of continually run, matching with the volume and expected turnaround time in the clinic setting. So as I mentioned, there was a lot of discussion about self-collected specimens, and the concept of collecting self-collected specimens in a non-clinic setting was well described by several presentations, and I just wanted to highlight two particular programs. One involved the care kit, and this was involved in multiple studies. This was described by Jenna Norelli in Emory. Several of the studies were examined and looked at overall return rates. The overall return rate for these assays or for these specimens was 38%. And Jenna had a very interesting comment on the effect of the pandemic, that they sent out these kits through an Amazon fulfillment service, and these fulfillments were stopped in spring to make room for more essential shipments. And so this also precipitated some thinking around the utilization of other commercial laboratories. The I Want the Kit test was discussed by John Melendez from Baltimore, who talked about the shutdown during March and April of 2020 of this program. But when it restarted up in April and data through June of 2020, he discussed increased orders of around 300% compared to pre-COVID numbers. Interestingly, the GC gonorrhea positivity rate remains similar to pre-COVID numbers. But one of the interesting things with this increased rate, and also with a national supply shortage, that there were becoming challenges with swab supplies. And this is something that we've heard from many different programs. So turning now to clinical trials, I wanted to select just a handful to discuss a couple different trials that involve antibiotics or randomized control trials and pilot trials around the use of various antibiotics. One was the use of cefixime, a presentation on the treatment for early syphilis. This was a pilot study where they monitored the RPR titer over 12 months and looked for a decrease of the RPR titer of greater than or equal to 4-fold. And as shown in this slide, there was out of 12 per protocol participants, 10 had a decrease in RPR titer of greater than or equal to 4-fold. Julie Dombrowski had discussed a presentation on a randomized control trial of azithromycin versus doxycycline for the treatment of rectal CT in men who have sex with men. And this looked over a 4-week period. And the doxycycline arm had increased chlamydia negative results by NAT. The role of kissing with respect to oropharyngeal gonorrhea transmission was debated earlier in this conference by Harold Chesson taking the con argument and Christopher Farley taking the pro argument. And the Omega clinical trial presented here by Eric Chow looked at the daily use of an antiseptic mouthwash in 530 MSM for the prevention of oropharyngeal gonorrhea. This particular assay did not demonstrate a substantial difference between the antibiotic or antiseptic mouthwash shown in green and Biotine, which was considered the control in this trial. So just turning to some post-COVID-19 considerations, it's important to ask, how have decreases in isolate collection are going to affect ARGC and genomic studies, especially when we look back over 2020? Another question that I think is really important to ask is, how are decreases in clinic visits going to affect our surveillance studies? We heard from Lisa Manhart around a Mycoplasma genitalium surveillance study at 8 different sites in the US. Having a delay, the first cycle was going to start in March of 2020, and obviously this is when the COVID-19 stay-at-home orders have occurred. Another question is clinical studies that rely on clinic visits. How are those going to be affected in the future as clinics reopen or partially reopen or have changes to operations? And then finally, we've heard many studies discuss the limitations on laboratory supplies and reagents, and we really have to understand how those limitations could potentially affect surveillance numbers, testing numbers, and so forth. But I don't think it's all doom and gloom. I think that there are many challenges, but there's also opportunities in the post-COVID world, or perhaps we could call it the new normal. Will implementation of self-collected specimens and point-of-care tests increase? And what other innovations will these drive? Will there be, for instance, tests that can actually be CLIA waived and actually performed in one's residence? How can we continue to obtain important data to drive surveillance and response activities? Could there potentially be more emphasis on culture-independent methods, such as the development of molecular methods to understand the distribution of antibiotic resistance in GC? And then finally, how will clinical trials continue to be conducted with limited access to clinics? And will we have to consider other potential settings? And with that, I would just like to thank the audience and provide my contact information. Thank you very much for listening.
Thank you, Sevgi, and I'd also like to acknowledge the great overviews presented by Laura, Ginny, and Brian. It's always nice when we have a conference of such diverse and massive content and we can't go to all the sessions we would like to, although the advantage of the conference this year is everything will be on a website. So if you missed something, you have opportunities to continue your learning. But it's hard to pull it all together, and I really appreciated the Rapporteur session, as always. So we're running out of time. We have to have a hard stop at 2:15. Maybe for some of you, that's good news. So one is I would just like to start with a few comments just about the conference and where we are today. And then we're going to get to announcing some awards and provide our thank yous and summarize some upcoming events for you to be staying tuned to. So the first thing is, I think that we do need to recognize that that we need to take a moment to recognize that this year's conference really was not like any other. COVID really has upended so many aspects of our lives, and this conference is no exception with our move to virtual format. And for many of you, you may not realize that we actually started on the path to having a live conference. We accepted a number of oral abstracts, symposiums, mini plenaries, and after that had to move to a virtual format. So I know it's been a long and exhausting 2 weeks, but I think an amazing feat. And certainly we want you to be filling out your evaluation so we can learn from this and hope to make improvements in the future. As you know, the theme was 2020 Vision, Disrupting Epidemics and Dismantling Disparities. These words feel more urgent and more relevant than ever before. The COVID-19 has exposed what many in the field of STD have known for years about disparities and the limits and weaknesses of our society's infrastructures and safety nets that included the basic level community trust. So we gathered to chart a way forward to discuss how we can adapt to rapidly changing public health and healthcare landscape and find new and better ways of working during the pandemic and beyond. In summary, I'm going to say we learned that more science and innovation is needed. I'm not going to go into the details of what I observed. We also know that our innovations need to be holistic. We need to start looking more at the context of people's lives, not looking at the individuals. We need to start looking at community of organisms and not just individual bugs. And we need to start using technology and take advantage of data science opportunities. So again, I want to thank you for participating over these past 2 weeks. The content was massive and diverse, and for helping us take stock of where we are, what this moment means for STD prevention and public health, and how best to move forward together. I think we all know that STDs are a societal problem, a collective responsibility, and a measure of our nation's health. So with that quick overview, I'm going to turn it over to my co-chair of the conference, Shaquetta Johnson, who is going to announce some awards. Shaquetta?
Thank you, Gail. And it has been an outstanding week. And throughout the conference, we've had several awards that were presented. So we'd just like to highlight those award recipients once again. First off, the Distinguished Career Award is presented to a person with a long and extraordinary career in the field of sexually transmitted diseases. And I think very fittingly and well-deserved that recipient was Dr. Gail Boland this year. The Achievement Award was presented to a person at mid-career to acknowledge an outstanding body of work in sexually transmitted diseases or to an individual for a single major achievement in the field. And this year's recipient was Dr. Gina Ogilvie. And our Young Investigator Award was presented to a person engaged in outstanding work in the field of sexually transmitted diseases who is no more than 7 years from completion of their training. This year, that award went to Dr. Claire Bristow. And now Gail will highlight our Jack N. Spencer Award recipient.
So the Jack Spencer Award is given to honor individuals for a career of exceptional contributions to excellence in STD prevention, characterized by outstanding commitment to science-based programs, continuous innovation, and profound commitment to helping people. This prestigious award is presented every other year at the STD Prevention Conference, and we are very pleased that this year's recipient is Steve Kowalewski from Pennsylvania, who's been leading the charge in STD prevention in Pennsylvania for many decades as well. So congratulations, Steve. And then our next award is for the Selfie with Science winner. And this is a poster contest where poster presenters are encouraged to share a selfie with their scientific poster on Twitter using hashtag STDconference20 and hashtag selfie with science to enter for the chance to win a meeting with me, which is going to happen this afternoon. And winners were randomly selected. So I'm really excited that I'm going to get an opportunity to talk to Juliana Baglietto. She is attending the conference from Mexico and has a very interesting poster on something that I love talking about, which is ocular syphilis in those living with HIV. Chiquetta?
Okay, and we definitely want to recognize our scavenger hunt winners as well. And these winners will receive waived registration to STD Engage in December. And Marian Pellegrini, Ronaldo Mabagos, and Deborah Polacek are our scavenger hunt winners. Congratulations, and we look forward to seeing you at STD Engage.
And I would now like to start our thank yous. And first, for those of you who have participated in the scientific committees for these conferences, we do not compromise our science by having people pay for presentations. There's a system to how the science is discussed and organized, and it's a lot of work. And so I really want to thank Sevgi for chairing the committee and for Jamie Littlecker for serving this year for the first time as a co-chair. Things are structured according to themes, not traditional professional backgrounds like epidemiology sessions or laboratory sessions. We really like to take a integrated approach. So we had the assessment track, which was co-chaired by Pradeep Patella and Hillard Weinstock, and you can see the names of all that were involved in our assessment content. The assurance track was co-chaired by Laura Bachman and Susan Phillip. The prevention and program and prevention track was co-chaired by Julie Dombrowski and Matthew Hogben. And our clinical and laboratory track was co-chaired by Philip Chan and Ellen Kirsch. The evaluation track was co-chaired by Patricia Dittis and Patty Kissinger. The policy track was co-chaired by Gail Bernstein and Bill Pearson. And the clinical case series was co-chaired by Bradley Stoner and Laura Quilter. And we didn't have time to list everyone who was members of these tracks, but this conference really would not have been as successful at all with all the great work that you guys have done. Chiquetta?
Okay, and also three individuals we have to acknowledge through this whole process. As Gail said, we started out planning for an in-person conference, which would traditionally have been our time to gather together, but midstream we saw the need because of COVID to switch to a virtual track. And Patricia Jackson, Shamika Jennings, and Allie Michele were on top of everything. And if it were not for these ladies, we would not have had such a successful meeting this year. So we cannot say enough how glad we were to have them on board and spearheading all of the logistics and making this conference truly happen. So thank you, ladies. And also we'd like to thank our sponsors once again. Without these sponsors, we could not have presented this conference so successfully, and it would not have been such a stellar convening of the minds. And NCSD, Logic, Abbott, and ASTDA, we thank you again for your continued support.
So, and I would like to add that CDC also really wants to thank NCSD for partnering with us to plan this conference. And I also have to say, I really appreciated having the opportunity to co-chair the conference with Chiquetta Johnson. It was a great partnership and a true pleasure. We'd like to let you know about some upcoming events And Shaquetta, will you introduce our next conference that's available to attend and learn?
Well, yeah, thank you, Gail. And it's been wonderful co-chairing with you as well. An absolute delight. And NCSD is hosting our STD Engage in December 1st through the 4th. We were planning to meet in New Orleans, my home state, but we have decided to go to a virtual platform as well. But as we can see with this week's conference, with the STD Prevention Conference, it does not take away from the excitement and the quality of the content, and we think that that's going to carry forward at STD Engage. So we invite everyone to join us in December, and we will have a great time, some great information, and please join us.
Thank you. And then I'd also like to announce our international partners that we work closely with. The two organizations, the International Society for STD Research and the International Union Against STIs, have joined forces and now have a biannual STI and HIV World Conference. This is the 24th meeting, and it will take place July 14th through 17th in 2021. So I also encourage you to stay posted with their websites to find out what's happening. I only learned recently, because I'd heard there was an initial proposal that there would be both a virtual and an in-person conference in Chicago, but I'm now hearing that they're going virtual completely. So that's good for us in the federal government, because we don't have to get an ICAP approval. So anyway, I encourage people to attend this very important conference in July of 2021. I'd also like to mention that the first ever STI National Strategic Plan, which has a vision, the United States will be a place where sexually transmitted infections are prevented and where everyone has high quality STI prevention care and treatment while living free from stigma and discrimination. And this includes all people regardless of age, sex, gender identity, sexual orientation, race, ethnicity, disability, geographic location, or socioeconomic circumstance. I want you to know that this is now up on the Federal Register. And if you go to www.hhs.gov/STI, you will be able to read this plan. And if you're interested in making comments, please submit them no later than 5 p.m. On October 1st, maximum 7 pages per set of comments. And we're really interested in feedback related to, or at least HHS is interested in feedback related to the draft goals, objectives, and strategies. Are they appropriate to address the epidemic? Are there any critical gaps in these goals, objectives, and strategies? And do any of the goals, strategies, and objectives, cause any concern? So there was a panel earlier, and I know that HHS is very interested in hearing from any of you who have interest in this plan or have time to read it. There's also another report that's coming out, we believe, early in 2021. The National Academy of Science, Engineering, and Medicine has formed a committee to look at the prevention and control of sexually transmitted infections in the United States. They were tasked with examining the epidemiologic dimensions, the economic burden, the public health strategies and programs, and barriers in the healthcare system and insurance coverage. So again, here are the websites to stay tuned to hearing more from this report. It's the nationalacademies.org's /prevention STIs or STI prevention at nas.edu. And lastly, we plan on having a conference in 2022. We have no idea what it will look like. More details to come. Please stay tuned. And just again, Shaquetta and I want to thank you all for joining us virtually this year. And we hope to see you sometime soon while we wear our masks and social distance. So thanks, everybody. And I guess I don't have to say safe travels home. Enjoy the rest of your afternoon.